Hi there, everyone, and welcome to this next part of session 2 as part of the NCRED Symposium. My name is Dr. Susie Hudson, and we've just had some fantastic presentations, really interesting about all the different trials that are going on in relation to methamphetamine use. And right now, we're going to be talking about communication and information sharing. And joining me today are a host of wonderful panelists. But we're going to kick things off with Dr. Monica Barrett, who is the Vice-Chancellor's Senior Research Fellow at the Social and Global Studies Centre at the RMIT University. And she's joined by Ms. Rita Bryan, a Research and Education Officer and Workforce Development at Turning Point. And they're going to be talking with you about co-design of clinical alerts as part of a drug early warning network in Victoria, Australia. Please pop your questions in the Q&A box and we will give them 7 minutes, and which time we'll have some Q&A. So over to you, Dr. Monica Barrett and Ms. Rita Bryan.
Hi, thank you, Susie, and to NCRED, obviously, for funding our project and providing us this opportunity to share our insights today. So this project is the co-design of clinical alerts for an early warning system, an early warning network in Victoria, and we'd just like to acknowledge our co-collaborators listed on the slide. So we'd also like to acknowledge the country of the unceded lands we both live and work, the Dja Dja Wurrung and the Wurundjeri country, pay our respects to elders past and present, and extend respect to all First Nations people who may be here with us today. So the Rapid Drug Alerts for Victoria project aims to facilitate effective communication of high-risk drug alerts information to clinicians, people who are actually working with people who use drugs. And we know that accessing this emerging drug market information is not always available to clinicians in these roles. So we aimed to translate data from existing drug monitoring systems in Victoria into timely alerts for clinicians, as their role is to prevent and respond to drug-related harms in the community. So the project was set up in 2 parts. The first part was to co-design with the clinicians to understand their requirements and their information needs from a clinical perspective. This would then enable us to implement the alerts and evaluate how this cohort would use them and their value in a clinical context. However, establishing Part B is still ongoing, so we're focusing today on the findings from the co-design process, which ended up being a large part of the project than we first anticipated. So the co-design process, this study was a mixed methods convergent study design. So the first thing we did was a quantitative scoping survey, and this established the need, context and relevance of clinical alerts, and also recruited for future stages of the project. And it informed how we then ran the 5 iterative qualitative workshops with people who work with people who use drugs. So first we empathised with the problems faced by clinicians through this process, and then we were able to define what was actually needed to create a successful alert. We then generated some ideas as to how we might design the alerts and how we would disseminate them. Then we created some prototypes, and finally we tested their acceptability and usability through a number of different feedback mechanisms with a wide range of stakeholders.
And it really was a very elaborate process, as you can see on this busy infographic that summarises some of our key findings. First up, alerts were seen as a really important tool for increasing exposure to emerging drug market information, as well as resources that could verify information that was otherwise being sourced anecdotally by many clinicians, and they were sort of forced to use their own personal judgment about the reliability of information at times. And so we came up with some key objectives of an alert system, obviously to reduce drug-related harm and support behaviour change amongst people who use drugs, but also to facilitate acute clinical management and non-clinical professional responses. And probably most importantly was to ensure education and information exchange within and across healthcare services. So especially where those communication channels weren't really very strong, as well as with, clients, patients and members of the community. And it might seem really obvious to state, but it was unanimous across participants that people who use drugs are the real target audience of any alert system. So that's regardless of whether the information's coming via clinicians or sort of other sources of information. So the alerts themselves had to be really suitable for these multiple audiences who had really diverse information needs. Even within services, workers had varying levels of drug information literacy and harm reduction knowledge, and they had to be shareable and easy to share. Time-poor clinicians were really not interested in repurposing or translating alert information. They were worried about misconstruing important information, and they just didn't have time. So the responsibility really fell upon the alert system to ensure all of these important features, design elements, and the critical information to include was suitable for everybody, and that it was packaged into one single alert bundle that could be shared universally. But we came across a bunch of challenges trying to do this. And I'll just summarise some of the key tensions that are very much worth mentioning. Firstly, alerts need to include really comprehensive key information and practical advice to meet the need of these heterogeneous groups, as you can see on that very busy table there. But it also needs to be clear, it needs to be concise, it needs to be relevant and accessible in a way that avoids information and cognitive overload. Alert systems also need to be careful about minimising what we called alert fatigue. So not sending too many notifications to avoid saturation, but also being very careful about not inadvertently gatekeeping valuable information in the process. And we really need to be proactive about building credibility and trust in the alert system itself, because even some clinicians were sceptical about the motives and the consequences of some alerts, particularly those that didn't have detailed background contextual information. So it's all about avoiding unintended consequences, obvious ones like promoting drug-seeking behaviour, but also not creating unnecessary hyperbole about the dangerousness of drugs in certain communities. And of course, absolutely ensuring that the affected populations of people who use drugs are not left behind in the process. So we created multiple levels of alerts to facilitate optimum reach and access to information. For example, an SMS prompt was necessary to give absolute need-to-know information people could opt into and then follow up as needed. But it was also a really useful tool for forwarding on to clients who aren't currently engaged with services. A detailed PDF information sheet, on the other hand, provides that contextual information and supportive actions. And it's quite easy to forward electronically, but also to download, print and display or distribute. But we did receive mixed feedback about the value of its clarity and the flow of information, particularly if someone was seeing it for the first time. So we then refined a more concise and action-focused summary flyer, which was sort of deemed more appropriate for placing in bulletin boards, waiting rooms and other public locations. And all three levels of alerts were necessary and considered useful in those different scenarios. But we also really needed to make sure that we created equitable access to the same level of information, regardless of who the person was, what type of information they were seeing, and where they entered the alert system or got notified. So we created this closed information loop where every notification point linked back or forward to a different type of alert format, so people could easily access the level of information that was most relevant and credible for them and their needs. So in summary, there are so many implications for ensuring effective drug-related health risk communications, and we haven't barely scratched the surface today. But essentially, packaged information has to be carefully designed and accessible in ways that suits everybody. There's no one-size-fits-all solution, but clinicians did want to be spoon-fed the information to facilitate efficient and effective information exchange. That being said, everything depends on the context of the alert itself, its audience, the information that's actually available, and very much so on the system or the alert system's credibility. So we can't downplay competing priorities that come up. We can't resolve them all either, but they have to be clear and at front and centre of the design and the implementation planning to make sure that we get successful reach and engagement to prevent the harms that we want to prevent. And you stay tuned for a couple of papers about that coming up. Just quickly point to our disclosures and our acknowledgements. And that's us.
Thank you so much, Monica and Rita. I really appreciate that. We don't have time for questions right at this moment, but please pop your questions into the Q&A box and hopefully we'll get to those at the end. I'd like now to introduce Associate Professor Suzanne Nielsen. Susie is a Deputy Director of Monash Addictions Research Centre, and she's also an NHMRC CDF Fellow at Eastern Health's Clinical School, Faculty of Medicine, Monash University. So over to you, 2, Susie will be talking to us about early findings from novel methods of surveillance for novel synthetic opioids and other psychoactive substances within supervised injecting facilities. Over to you, Susie.
Perfect, thank you. All right, so I'm talking today on some work that we've been doing, looking at new methods for monitoring for the emergence of novel psychoactive substances, which would feed into the kinds of information sharing systems that Monica and Rita have just talked about. So this is work that we did within supervised injecting facilities, which provide, I think, a novel opportunity for monitoring for these substances. And I just wanted to acknowledge all of the collaborators that you can see on the screen there. So in terms of the background, we know that there have been really concerning trends with novel psychoactive substances such as fentanyl and other synthetic opioids. The aim of this work was to try and look at some new ways that we could monitor for their emergence, given that we've seen really devastating results from these substances overseas, but we haven't really seen them sort of emerge consistently in the Australian market yet. So I'm going to talk about 3 different types of surveillance that we did as part of this study, which includes looking at testing anonymous sort of volunteered urine samples from MSIC and MSIR, the 2 supervised injecting facilities in Australia. We also did a drug checking study within MSIC in Sydney, and we also looked at testing overdose equipment as well through both MSIC and MSIR. So in terms of testing the urine samples, what we did here is we had 10 waves of monitoring. We've done this since 2017, and so far we've had more than sort of 900 samples and surveys that we've completed. What happens when participants come in during a wave where we're collecting data? They're invited to participate. They can provide a urine sample, which we'll test with these with the fentanyl test strips, and they also complete a very brief survey, and that's so that we can understand what substances they think that they've used in the last couple of days, so that we can identify if unexpected fentanyl was in those samples. Where we get a positive sample, then we send those samples off to the lab. This was commenced in 2018, so that we can actually confirm what substance may have caused that positive result. So far, amongst these 10 waves that we've conducted, we've had 17 positive results. Most of those positive results have been from actual pharmaceutical fentanyl, and these effectively act as positive controls, confirming that we are identifying that with our test strips. But we did have 8 unexpected positive tests, where on the survey that people completed, they reported that they'd only used heroin or other pharmaceutical opioids, but the test was positive for fentanyl, which hadn't been used. So for those, 6 of those positive tests occurred after we started sending off labs to samples to RIFM for confirmation. And only 2 of those were actually confirmed to have fentanyl in them. So we had 4 what looked like false positive results, but two confirmed samples in June 2019, where we did identify evidence of unexpected fentanyl in the heroin supply. The next method that we looked at was drug checking within the Sydney MSIC. The way that this works, so this is a pretty standard method that's used in a lot of parts of North America now, is that after you have mixed up your heroin and drawn it up into a syringe, you're able to test this sort of container that you've mixed the drugs up in by adding water and testing the wash. Now, you can do this before or after using the drug, because the drug's already in the syringe. What we did is also do just a very brief 1-page survey just to ask people about their experiences, because we did want to understand the consumer aspects of kind of how acceptable and valuable they found this process. So we initially got research approval to do this after getting these couple of positive results in 2019. We thought people would be really interested in testing their drugs at the supervised injecting facility in Sydney. It turns out there actually wasn't that much interest. People didn't necessarily want to test their drugs before they used them. So we changed up our research procedures in 2020 to add a reimbursement. So we would have just a $10 voucher that people could receive so that we could gather that information on consumer perspectives around doing this testing. So it was still fairly slow going, but we had 35 people that did test their drugs and complete the survey. Partly that was slow because of COVID, which obviously impacted on us. But we did find a couple of interesting things. So firstly, we found that there was much more interest in testing drugs if you could do that after use, which might sound kind of counterintuitive, but I don't know, we'll talk about that in a minute. But essentially from both our experience, most people did test their drugs after they'd used them. And from the results of the survey, there was much more support for testing after use, not that much interest in testing before use. We also found this issue of false positives again. So of those 35 tests, we had 2 that the test strip tested positive. We sent those both off to the lab at UTS and both appeared to be false positives. The other issue that we found is that the test strips themselves are commonly misread. And so we had a lot of work sort of backwards and forwards confirming with staff to make sure that tests that looked positive were actually positive. And that's often to do with the fact that you need 2 lines to be negative, which is the opposite of a pregnancy test. But also if you have any line, even a very faint line, that's actually read as a negative, but often those faint lines are hard to see. It is important to think about this impact of false positives, and I've just got a very brief note on this. There was a maths kind of nerd and clergyman in the 1800s called Bayes, who has a kind of a formula for calculating the impact of this. What's important here is that when you're testing for something which has a really low prevalence and a very high false positive rate, or relatively high false positive rate, and when we say high, that could be, you know, less than 5%. What actually happens when you do a lot of tests is you're still likely to be giving a reasonable amount of people bad information. And we think this might be an issue for fentanyl test strips in Australia. And I guess this underscores the need for kind of lab confirmation or other more sophisticated methods and not just using the test strips on their own. The other issue that we found that I touched on is that it's quite different. A lot of research around drug checking has been done in festival situations. These are kind of like planned events with a bit of a lead time. We found that people were more interested in testing afterwards to maybe inform future purchases rather than for before use. And this was just a quote from a participant, really highlighting that when I arrive, I have my drugs and it's unlikely I'll stop for testing. All I want is to get in. That's the priority. So then when we look at the final test, we looked at testing overdose equipment. We had, again, this was COVID impacted. We had 37 overdoses where we collected up the injecting equipment and sent that to UTS. What we found is, in fact, almost all of those were just heroin that was identified, including expected contaminants and impurities. We had 1 blank syringe, but we didn't find fentanyl or other NPS, and we really just had a couple of trace amounts of cocaine on the spoon and a few trace amounts of other substances. But essentially, it seemed like heroin was causing all of the overdoses when we tested the injecting equipment. So in terms of our conclusions, we found that all 3 methods were feasible and implementable and acceptable. But there was really limited evidence of fentanyl that we found across all of the methods that we used. In terms of the relative pros and cons, testing urine is quite useful when we don't have many signals because you get a much wider window. You can actually test everything someone's used for 2 or 3 days in effect, rather than just testing a single drug sample, but it does have a bit of a greater impost on consumers and services. In terms of drug checking, that was easier to do, but as mentioned, those false positive rates may undermine the value and they may undermine confidence in testing when we can't rely on the results if we don't have lab confirmation. And finally, testing the overdose equipment. Again, this is really important data. Most overdoses don't go to emergency departments where a lot of surveillance happens. So it is important, but we probably need faster results to be valuable. And just final slide, sorry, just to kind of flag how this all fits together. We've been doing some workshops with consumers and other key experts to identify how to use this information. And effectively, the conclusion seems to be that ongoing surveillance for fentanyl probably isn't warranted at this time. There's an opportunity cost, particularly within a supervised injecting facility, where time spent doing this is time not spent doing other harm reduction activities. So effectively, the discussion is around sort of waiting until we get signals, then rolling out some of these testing methods that we've kind of developed and know are feasible, and having that feed into responses like the Prompt Response Network and others that you'll probably hear about today. So just a final thanks to everyone that's contributed data and their time, and again to acknowledge NCRED as the funders of this work.
Thanks so much, Susie. That was really fascinating, and hopefully we will come to some questions at the end. But I'd like now to introduce to you Ms. Penny Hill. She's from the Prompt Response Network lead from NCRED and is an Emerging Drugs Research Fellow. And she'll be talking with us today about heading towards an Australian prompt response network for emerging drugs. So over to you, Penny.
Unmute. Can everybody hear me and see my screen okay? Yep, sounds like it. Okay, great. Thank you everybody for having me here today. As Susie just mentioned, I'm from NCRED, so we're really excited to have everybody on the line today. I'd just like to start out by noting that NCRED is funded by the Commonwealth Department of Health. So I'm joining you today from Gadigal land, so I'd just like to pay my respects to the traditional custodians and also elders past and present. So I'm starting to race through because I know I don't have much time. So just to start with some background, typically about 500 new psychoactive substances are reported and identified to the United Nations every year. I'd just like to point out that while the UN and a lot of other agencies use the term NPS, we use the term emerging drugs, which is used by the Australian government and defined as new psychoactive drugs that appear on the market in Australia, including novel drug classes, which are potentially harmful, but also including new formulations of older drug classes for which problems related to their use are emerging, so including methamphetamine. So I also just threw in this picture just this morning, just to note that up until this week, this report was just has just come out this week. There's been about 200 reports of NPS from Australia up until 2021. So for a bit more background on the international landscape and where that report, the NPS threats report comes from the UN Office of Drugs and Crime Early Warning Advisory on new psychoactive substances, which Australia is a part of, obviously, because we just had the numbers of how many substances have been reported. And this program is administered by the Global SMART program. So we also have a current UNODC strategy that recommends early warning systems that to encompass both health and law enforcement approaches. And coming out this evening, I believe, Vienna time on Friday, we have the new UNODC synthetic drug strategy that's going to be launched today, which has a whole sphere on early warning systems. So looking forward to reading that report very soon. And just to provide a bit of context to the Australian landscape, we here at NCRED have been actually funded through the recommendations of the National ICE Task Force. And but there have been a range of reports and recommendations for various forms of early warning systems and health-led early warning systems in Australia. But as you know, we live in a federated country, and we've got different events and recommendations that have led to differing local early warning systems being set up across our different states and territories. So today I'm going to present briefly on the challenges we've had in setting up a national prompt response network and the proposed solutions that we have that we're going to be implementing to strengthen the sharing of information about emerging drugs across Australia. So this looks like a complicated map, but this was the start of a very extensive and intensive mapping process we went through with stakeholders all around the country who are feeding into their own local early warning systems. We started out by reading up on consultations, many done by Susie Hudson herself, before I joined this project about a year ago. And then we sat down with stakeholders to really map out what processes are involved in their early warning systems. And this is actually just a screenshot of the very first day we did the mapping with just one jurisdiction. So we now have a very complex map that we're aiming to simplify a little bit and hopefully be able to share publicly. So as we went through this mapping process, we determined that most local systems have different stakeholders involved in their system, including, for example, some include law enforcement, some don't, some include peer organisations and some don't. There's different lead agencies in each jurisdiction, and each local early warning system fits into the differing health systems we have across different states and territories in Australia and have different government agencies feeding into them. There's also different communication processes for every state and territory early warning system, and also varied levels of formalised processes. We realised through that mapping process as well, probably won't be a surprise to anyone, there's extremely limited resourcing and sometimes no resourcing for some of these systems to be set up, and they're led by absolute champions at the local level, bringing together to a network to share information through. And there's also really low awareness of what's happening interstate and who's doing what elsewhere. So overall, we learned how the PRN can support and enable and further enable the varying systems around the country, some existing and some emerging, and what we can do to coordinate them to bring together the stakeholders involved and other relevant stakeholders at the national level. So just quickly, we've defined the Prompt Response Network as a national network bringing together existing and new early warning networks across the country. And our mission is to coordinate participants to share information and knowledge for timely public health responses that will reduce the harmful effects of emerging drugs. So to enable us to deliver this mission, we have defined some key high-level objectives for the PRN's response, and that includes establishing the national network of new and existing organisations and networks to enable flexible participation and information exchange. We're going to develop rapid communication and response protocols that define outcomes and actions for topics of interest, and identify and disseminate the information and knowledge needed to support timely decision-making through a program of activities and supporting technology. So just to get into the solutions and what we've done so far, as I mentioned, we've gone through that really extensive mapping process. We've also brought on board collaboration specialists and system architects to determine program technological and security solutions for the PRN. And in doing so, I've recognized the key role that technology will be able to play in the PRN. We've also created maps of functional and tech components for the PRN, which I'll show in more detail in the next slide. And we've established a PRN roadmap for the next stages of the build and ongoing protocols for the project, noting that the implementation of the PRN will evolve over time and work to identify what system and structure will best meet the needs of all of the jurisdictional stakeholders. So this is a quick diagram or high-level diagram of the components we've determined through that co-design and mapping process that need to make up the Prompt Response Network. So I'll just start with the PRN core functions, which make up most of the diagram in the blue box. We also have the public-facing website in the purple at the bottom here, which will act as the hub for all relevant alerts, resources, and information from around the country that will be available to the public. But back to the big blue box in the restricted component on the left-hand side in the green diamond, we have what we're currently calling the National Incident Register, which will bring together incident data from the different state systems and national projects, which will be able to be accessed by key lead PRN stakeholders. And then on the right-hand side, we have the blue rectangle, which we call or currently calling the National Trend Dashboard, which will bring in all the contextual information and resources needed from various data sources and relevant research projects such as Susie's around the country needed for those stakeholders following trends and considering putting out public health alerts. So what's coming for the network? I've still got a very busy rest of financial year trying to bring together all of these components in the next 7 months, but we're aiming to actually activate the network with a community management online platform, which we will be trialing in the next couple of weeks and expanding from then on. We're also hoping to launch a public website in the next couple of months as well. We will be building the National Incident Register. We've engaged developers to build out those components, which will start at the beginning of 2022. And we're currently going through a very extensive governance and authorization process to work out how we can have the data feeding in to the National Incident Register. And we're also going to be activating that National Trend Dashboard. And then from that point, we hope to broaden network participation and also establish an anecdotal information portal for the public to report information into the system that they would like to. sorry, I raced through that, but here are just some of the incredible range of stakeholders that have really been working closely with me this year to get to this point where we've determined those components. I'd also just like to, I'd like to thank them for their time spent on the project, and also thank the NCRED board and of course the Commonwealth Department of Health as the funders of the Prompt Response Network. Thank you.
Thank you so much, Penny. That was fascinating and really exciting to see these things coming together. And in the moments that we have left, I'm hoping you'll pop some more questions in the Q&A box. But I suppose what really resonates for me is how all these projects fit so nicely together, and how important it is for us all to really support projects like this and the sharing and the collaboration of information, even though we know that at the local level there are lots of differences, and that's absolutely fantastic. It's how we can bring that information together. Now, I might invite all of my panelists to join me on the virtual stage, if that's okay, in the last couple of minutes that we have. And I'd like to start by asking Susie Nielsen. I've got a bit of a question in the chat box, in the Q&A box. And Charlie was just wondering whether the injecting centres in Victoria and in New South Wales have been involved in the SMS alert systems. Are you able to comment on that?
I wonder if Monica can comment on that, actually, because we didn't have SMS alert systems as part of our study. They themselves could probably tell you. I know that Sydney MSIC definitely feeds into New South Wales health information with what they get. I'm not sure if the question was asking about that or about what Monica was talking about.
Yeah, what we were talking about was all hypothetical, and it was something we've produced that would then be used with existing information, but it wasn't something that we actually implemented. So in terms of our system, the answer would be no, but indeed Penny might be best to answer this one, because you might know that if something else is happening we're unaware of.
See the collaboration that's going on right here.
Yeah, exactly. This is the perfect example of the projects such as Monica's and Susie's that are feeding into the PRN and enabling us to really design the best response for the Prompt Response Network. I believe Monica's project found that SMS alerts would be needed in the Victorian system, and that's a finding that we can take to all of our national stakeholders to determine if that's what's wanted at the national level when we launch the public-facing side of the PRN. But it's also really great to have Monica's findings conveyed to all the different stakeholders who are all running their own systems and putting out their alerts. And those alerts currently go out sometimes via email lists and on social media and on public websites as well. So all of these great findings are just feeding into how we can improve the network. Or establish and improve the network. It's not started yet.
Well, I think, and maybe I could turn to you, Monica and Rita, at this point. The co-design process that you undertook, I suppose, tells us something about the importance of bringing people along on the journey. And I wonder, in terms of when we think about early warning or prompt responses out to the community, do you feel like a similar type of process with consumers would be of benefit in terms of how people would like to receive messages?
Absolutely. Wouldn't you agree, Rita?
Yeah, 100%. We were starting out designing, alerts solely for clinicians, by clinicians for clinicians, essentially, and it became very apparent very quickly that there was a massive part of our co-design, well, not missing, but opportunity there. And part of the people who use drugs also need to be part of the evaluation process as well.
That's great, Rita. I think you're absolutely right. And I suppose too, what I'm hearing too, and I suppose Susie, you mentioned this in terms of what people want to do in terms of process, in terms of their testing. And I suppose it prompts me to wonder about not only the consumer involvement in informing how we do things or the process, but also, I suppose, creating a bit of a different culture, because of course, people in Australia, having not had ready access to testing their own drugs, this is a bit of a culture shift perhaps. And do you think, and maybe this is sort of to all of you really, do you think that with some more good credible information coming out, this opportunity for testing, do you think that people then become more able to consider, or the culture changes in terms of testing of their drugs? Susie, do you have any thoughts on that as we sort of bring this to an end?
Look, I think one of the things is that I think it's really interesting to think about it, and it's so critical to work with consumers in who use drugs, and particularly who use opioids, because it's quite different. A lot of research has gone on in the festival scene, and as I mentioned, they're planning those events for a long period of time. They're potentially testing their drugs not while they're in a state of physical withdrawal. They've got more time and it's less kind of pressured. When you're talking about people who may inject drugs multiple times per day and have multiple sources, then it's a lot more of an impulse to be testing and testing and testing. And when do you test? When do you not test? And the very clear message we got from consumers is when you've just walked into the supervised injecting facility and you've got the drugs you want to use, they've got no interest in testing. I mean, they're at a supervised injecting facility, so if something goes wrong, they're in the best place in the world already. There was more interest if people were going to be out in the world and not in those sorts of facilities. That was when it was considered perhaps more valuable, but I still think we need to think about the reliability of these testing strips, and are we giving people good information? Can we give people access to better technologies rather than just these test strips? And I think that will help change the culture, particularly if people know that it's reliable and it's quick. I don't know how to get around that issue of needing to do it so many times a day potentially.
Yeah, look, I think there's a lot of work yet to be done, and I hope too that we start to see some reasonable and pragmatic approaches, I suppose, to the availability of these, not only of testing, but also that sharing of information. Now, I'm aware we're running out of time, and I know that we're coming up to a break. There are a couple of questions that are in the Q&A box right now, and I'm going to invite our panelists to respond to those so that you do get an answer to your questions today. But we've now sort of come to the end of this particular session. We're going to have a break now until 1:15, and then we want to encourage you to join us again for session 3. So if you could now take a break, grab yourself a bit of a sandwich or whatever you're up to. We'll see you at 1:15 when we'll be talking about treatment and harm reduction. Thanks for joining us.